using multi-drug regimens for our patients, we have gone from the doublet to the triple, and now we have 4-drug regimens are very common. So, there is that conversation with the patient about side effects, but we need to keep in mind that when we're using these multi-drug regimens, we do dose modify. So, the idea is that you are giving all these drugs, but you're not giving them necessarily at the highest doses to cause, that would cause more side effects. So I think, the biggest change I saw was last year when, after the Griffin trial, when we added daratumumab up front, we had a lot of questions from patients about that. They were used to reading about RVD induction, for instance, but there were a lot of conversations around, why are you now adding a 4th drug? Because we tend to know about these things before patients hear that data. I think patients in the myeloma world are just used to it. It's rare, unless you're in that maintenance setting, to be on one drug. We do still see side effects, and we have to listen to our patients and make those dose modifications. So we're monitoring those patients in clinic, but then we count on our nursing staff to monitor as well. So if they're coming to the infusion center for subsequent treatments, or going to one of our other locations to an infusion center, we're counting on those nurses to monitor those side effects and call us if there's an issue.
Moving forward with multi-drug combinations for multiple myeloma, of course, patients have some apprehension with having more medications because, let's face it, nobody wants to take any more medicine than they have to. But I think one of the most important things that we as providers can do is to educate our patients on why we're recommending triplet and even quad therapies now. And that would be that overall response rates are better, and patients tend to have deeper and more durable responses. So I'm speaking specifically to the Griffin trial as well, where we saw that patients got a deeper and more durable response with the addition of daratumumab.
Well, and I think too, we need to remember, right, we have patients who come to us that are really sick, and we make them feel better with these drug regimens. And then we have those patients who have no symptoms that we start them on treatment, and now we've given them side effects. And with these regimens come antivirals. If they're on an immunomodulatory agent, they're going to be on something to prevent thrombosis. So it isn't just taking these drugs, right? It's the other things that come with it too. And then if they're already on other medications, I mean, you're absolutely right. Patients look at this and go, oh, so much medicine that I'm on.
I completely agree with you. I think it's not just the triplet chemotherapy regimen or the quad chemotherapy regimen. It's adding an antiviral twice daily, adding DVT prophylaxis, and then oftentimes adding bone modifying agent like zoledronic acid. So they're not just getting the myeloma directed treatment, they're also getting a lot of supportive care. So you can have someone who was only on one blood pressure medication and now they're on several. So I think that can also be a big change for them.
Well, and then you look at some of the problems that we can cause as well. If you think of dexamethasone, patients that are diabetic or develop steroid-induced diabetes, thyroid issues, so those other components as well.